Thank you all for joining us this morning. I thought those were three excellent presentations and generated some great comments and some questions and for all of us to think about. Judy, what we're doing right now is, again, as I mentioned previously, if you have some questions, please send them in to us right now so we can discuss them. And we're on the chat, in the chat room ourselves, right on our site, and we're going to read some questions that have come up. Judy, do you have some there that we can share with the audience?
I'm going to admit I'm using Michael's computer. Here comes Michael, and we'll be a little more empowered. A comment from one of my peers in my community, Dr. Claire Coco, who is a primary care physician, on the EHR system Vista. She believes it's not a good model, but the use of a single system is the key to providing individualized care to a large population. Her choice would be Epic. Is eminent domain an option? So Claire, you may need to send us a little more information, but I think your question about eminent domain. Let's see if anybody has
any thoughts on that, Michael?
Now, is Vista the VA computer system?
I don't know.
I don't have any experience with Vista. And go ahead, take that.
Okay.
My experience with the VA ended in 2011, so I don't recall exactly. But when you talk about, I hear a lot of talk about interoperability, and we should have one standardized system and all.
My computer.
I don't think that's a priority. I agree with Senator Cassidy. That is, or Mike Kruchek maybe had said that. It's not a priority. To me, the priority is high quality care of the patient. And we can worry about interoperability later. One thing I've learned about using these systems is in my last employed position, I was told, well, we'll have the medical assistant do a lot of the H&P for you. And then all you've got to do is edit it and sign it. And I told them, well, it only takes me 3 times as long to do that as it would to do it myself. But what I learned from that is learning the patient, a lot of that has to do with me writing down that history and physical. And that's what puts it into my brain. And when I go back a month or 3 later to remember that information, just reading a few words of that brings that memory all back usually. Whereas if I was not the person who entered it, that doesn't take place. Plus you have the issue of the quality and the accuracy of that data. As a physician in attendance, you have to verify and guarantee that that information is correct. So we had a magnificent system in my private practice, 2005 to 2010. It was not super sophisticated. It was a Word document that I dictated to. And we had a couple of other folders for scanned documents and for our old chart, which we would update every year. I would have 2 other windows open, one for medical reference and the other for an instant messenger with my staff. And that really worked magnificently, as I said, especially once we learned that some of the patients' charts got unwieldy and we were getting a lot of call-ins for refills, and we learned on those patients who have chronic problems to have them come back once a year. We would copy and paste the old H&P. We would put the chart, the chart that had become unwieldy, into an old patient file. The medical staff, medical assistant would go through and verify the new medicine list and have that intake all up to date. And then I would go through and verify everything that was in the rest of the body and update it and change it as need be. So once we got finished, we had a great, nice, clean, updated H&P. We would address all the chronic problems, make sure that the labs were up to date, and then we would refill all the medications for 1 year if they were long-term meds. And we made sure all the preventive care was up to date. So when I would refer to another physician, to a specialist, I would typically just make a new note on the updated information, why I'm referring, or if there was a pre-op physical for surgery, again, the new information. And the staff would send that along with the latest H&P. And that system worked really well. I got a lot of compliments from physicians. Another thing I would do is bold the diagnoses and any of the really major points, such as a cath report, so that they were really easy to find. So my point is, when this information went to the other physician, another hospital, wherever, they had a really crisp, concise, readable, and yet detailed document. Now, they would have to, if they have another EHR, of course, enter that information. They could, of course, scan it as well. So that takes some additional work, but again, I'm not certain, at least at this point in time, at our level of what we have to work with, that interoperability is the key issue.
Yeah, so that's interesting because you kind of did what Dr. Karuchek was talking about. You took a system and you fine-tuned it a little bit, right, to your own way. You kind of made it work and tweaked it, so you had, at the end of the day, a pretty good record.
Right. Actually, I had started to practice in 2005. I was with a hospital who was doing a pilot project with McKesson. And they said, the hospital told me I could be part of that, get that system for free, but there were delays, and it took almost a year after I opened my practice before it was available. So we had to have something in the meantime we could use, and that's what we came up with. I hired an IT expert who did a wonderful job. And as you said, and as Mike Karuchek said, we were in a position where the physician could tweak it as time went on, and it got better and better. When the pilot program did finally roll out, it was so cumbersome, so difficult to use, that there was no way I was going to switch from my system over to that. But I did offer to consult on it, and that seemed to displease the people in my hospital who were part of that project, and they just came and took their equipment, and that was the end of that. Yeah. My one other real experience was in my last employed position, 2012, with an all-script system, and I had lots of trouble with it. I remember, I think, Dr. Karuchek saying something about the various boxes and windows you have to click back and forth, so that what that means is that you can't assemble a coherent, unified picture of your patient. And I told my hospital that that's what doing a history and physical is about. It's like a jigsaw puzzle. Some of the pieces are scattered, some are flipped upside down, some you've got to look for, but you assemble that picture, and once you have that unified, coherent picture, now you can refer to it. Next time you can build on it. And I wasn't able to do that. There were always multiple different windows and boxes where the information was. So what I ended up having to do often was write down the lab results, write down something, go to the next box, so that, again, I could have that all in front of me.
Yeah.
I was told that all scripts would not help fix those problems because I believe their contract had run out in terms of support. And I verified that. I called them and told them I was having trouble taking care of my patients with it, that, you know, I couldn't take competent care of them, and just received no response. So there was no mechanism to improve that situation.
You know, what I see a lot by all of these EHR vendors is, I think one of the things that has got us into trouble where we're at is and I'm going to speak to this on Saturday. Excuse me, I got a cramp. I'm going to speak to this on Saturday in my presentation, but and I mentioned it to Dr. Cassidy, is our evaluation and management codes. I'm going to back up here because my muscle's cramping on live TV. Is our E&M codes, because these EHR vendors and these systems that were rushed out know that the doctors need to document so many bullet points in how they speak in their history and on their physical exam and on their review of systems and in the past medical history. And we know they have to do that because if they don't do that, they don't get paid. So we have to check all these bullet points, and that has led to all all of these, this is my own experience, but all of these drop-down menus and bullet points, because they know, they come out of this, and here's what they do. Here's how they sell it. They say, oh, and you see, doctor, if you drop down this and you click on this and 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 this, that gets you 99215. That gets you 99215, and come on, House of Medicine, all of you out there, you know, you were sold that. They told us, and they told you, you can upcode. You can raise your code. You can get paid more money. You know that happens. It's happening. I think it's wrong, and I think one of the things we need to consider changing, and that's why I suggested it to Senator Cassidy, is we need to decouple billing from EHR documentation. If we did that one simple thing, and I hope someone's out there is listening, but if we did that one simple thing, it would get, in a moment, it would get rid of note bloat, these 7-page notes, and we would go back to a time where the physician would only document the pertinent medical information. And so, if you ask me, that's what I would do, and I think that would be a good start. I don't think these EHR systems are really listening to us. I don't think they are engaging physicians. Maybe I'm wrong, because I'm not in the rooms, and I do think if you're listening out there and you're an EHR system, boy, I think the first person out of the gate that starts consulting physicians and asking them in a very serious way, what do you need, what do you want, and how we can help you, the first EHR system that does that, you're going to strike it rich. So that's a challenge for all of you out there. Judith, any questions?
Yeah, I want to circle back to the question that we had earlier about the VA system, and I had a question about what Claire said, and I'm sorry, I'm having a little technical trouble myself. Anyway, the program that we were talking about was in fact the VA, and the way that came up was, and it pertains to Claire's question about eminent domain also. I'm going to step back to a personal experience where my father, who was a retired member of the Department of Defense, sustained an injury. This had to have been 15 years ago, and then needed to travel. And it was very easy for him to travel and have continuity of care because there was clear communication between the facilities that were providing care for him. So I was at a meeting recently in South Carolina and asked a representative of the Affordable Care Act who presented at that meeting, if we have effective electronic health record system working for the Department of Defense and working for the VA, I had heard good things about the VA program, why don't we just use it? Why are we reinventing the wheel? Why did we need a high-tech act? Why do we need EHR companies vying with each other to obtain government money and disregard the end user, which is the physicians? The other thing I wanted to say was Dr. Cassidy asked that if we had any granular suggestions that we send them to him. And I have a very granular suggestion to send to him, and that is for the federal government to get out of the electronic health record system. And that was the same thing that Dr. Kuracek said. Wow. Just as Dan said, if we would decouple federal funding from the electronic health record system and let these private companies turn to the end user, find out what our needs are, and meet our needs, this problem would go away in a heartbeat. And somebody would probably make a lot of money doing it, and ought to.
And my only point on that, and I think Michael kind of countered back on me, the reason I suggested, well, what is there a role for Congress, is simply because with where we are at today with these mandates and high tech and all of that, the ball is swung and the power's in these EHR systems. And so until we let the free market come into it, someone needs to hold the EHR vendors accountable, whether it's by, you got to have a safe system out there and you got to meet certain certifications. I agree, it should be the free market, but that's not where we're at quite right now, today.
Well, I agree with you guys completely, and I want to address Claire Coco's statement here. She says, we should stop trying to get all of these systems to talk to each other and all of us work from the same system.
And that's what she meant by eminent domain.
Right. I understand the appeal of that idea to have a single standardized system, and and I could appreciate some of that myself, but I think it's never wise to have just a single system. That's just like having an inbred population. You get decay, you get degeneration. You have to have that competition and cross-matching to end up with high quality. So I don't see how we can do that, although I do see that there would be some advantages. Also, to Gene Dorio, he says, primary care physicians have been markedly impacted and overwhelmed by EHR, insurance companies, denials, et cetera, et cetera. What direction can Let My Doctor Practice go to provide them with relief? Well, Gene, I would say that Let My Doctor Practice doesn't really have a lot of answers as an organization. It's just a platform to allow physicians who have the expertise to come together and discuss these solutions, and may the best ideas float to the top and gain support.
But one thing, Michael, and sorry to interrupt you, speak to there later in the week, we are going to have physicians speak on some pretty creative ways that primary care physicians are now managing and treating their patients.
Right, there are some direct patient care physicians who've successfully implemented those models. Josh Umber has a cash monthly membership family practice, and Keith Smith, a cash surgery center. And both of these seem to have done tremendously well. In fact, I've adopted Josh Umber's model in my own practice as of January, and I really like it.
And they're both, right, Michael, going to be speaking at our conference. And
yes,
again, just to check go to our Let My Doctor Practice website, go to the conference. You can click on speakers or click on topics. You can go to schedule, and you'll see exactly when those speakers are going to be speaking. So stay tuned, because they have some great talks, I'm sure.
Right. And I agree, Dan, I really love your idea of decoupling billing from taking care of the patient, from clinical documentation. And I know our speakers really agreed with that as well. I want to get back to a little bit about this. For instance, Gene's comment about how doctors have been overwhelmed, and what you've talked about the EHR companies not listening to the doctors. As Dr. Karuchek mentioned, the physicians are not the EHR companies' clients or customers at this point. It's the government, it's the hospital, it's the large organization, it's the administration. There are some reasons for that, various reasons, but one of them is that the government is taking our tax dollars and using them to favor large systems. Apparently on the theory that patients get better care in those systems. I don't know that there's evidence to substantiate that. I'm not opposed to working in a big system, especially if it provides better patient care. I've worked for the VA in a big public system. But what I object to is the physician not having the ultimate authority over the care of the individual patient before them. I'm also a pilot, and I see a lot of analogies between the two. As a pilot, I've got a plane load of passengers that are my responsibility, that their lives are in my hands. And in aviation, there are a lot of rules and regulations we have to follow. We have to follow instructions from air traffic control. However, the pilot, as the captain of the airplane, has the ultimate authority. Mm-hmm. And if they are directed by ATC to fly into a mountain or a thunderstorm, they have every right and also obligation, duty, to disregard those instructions. One difference between aviation and medicine is the pilot is right there with his patients. If something bad happens, he or she's going to be right there with them, whereas the physician is somewhat insulated from that, but still indirectly shares their fate ultimately. So these administration employers, non-medical employers, these EHR companies and systems that are telling doctors how they must practice and not giving them that ultimate final authority, they're really practicing medicine without a license. I know that technically or legally they may not be, but if you direct the physician and the physician has no choice, then you are practicing medicine. And so I think one of the keys to quality patient care and to protecting the patient is that the physician, and there are other clinicians who see the patient eye to eye, face to face, and also who sign and take personal legal responsibility for their diagnoses, their documentation, for the orders and recommendations they make. And so that, I think, is the patient's best chance at being protected from malpractice and error. And so I would hope that the state legislatures and perhaps the federal government, whatever role is there, would enact laws to protect that situation, to make the physician the final authority and also to bear the ultimate responsibility for their diagnoses and recommendations.
Yeah. Any thoughts, Judy?
I do have some thoughts, but they're along another line.
Okay.
And that repeatedly this morning, we have heard about the importance of physicians participating in everything that we do. You know, actually, as I was listening to Michael, I have a little bit of a different story to tell. And that is that by and large, through the course of my practice of medicine, I have been a non-compliant physician. I pay penalties. I don't get bonuses. I see fewer patients. I take all the time I want. If I'm in the hospital using an electronic health record system where I'm not completely comfortable with what I'm doing, I insist that one of their employees is sitting beside me executing the function. And in my mind, the hospital has to pay for an employee to be there beside me to use the tool that I may, in some circumstances, or maybe in another set of circumstances, not feel safe to use. So that being said, I do believe that we do have some options. And there may be times when we're absolutely told what we can and can't do. I'm thinking of breast cancer patients where specific imaging may be called for and a third-party payer declines to participate in the paying for the imaging. I don't see that as them telling me what to do. I let the patient know that there is a recommendation, whether it's NCCN guidelines or a set of criteria, best practices criteria set forth by my national organization, but the third-party payer with whom you have established a relationship is not going to pay for the service. Now, we can go ahead and proceed as we wish, but you're going to have to accept financial responsibility for it. And as we move through the summit, we'll see once again, as we're seeing in email streams and other internet informational sources right now, that the real solution to many of the problems that we're dealing with right now is to have financial transparency and degrees of financial accountability for the patient. And let that third party get out of the relationship. Let us do, as Michael just said, sit down, define the circumstances, look at what the options are, see which option is important to the patient, and then, you know, if you have to, even what you can afford. That's the real world. That's the way it is in other countries, and ultimately that's the way it's going to be in this country. And allow people to actively participate, engage in dialogue about how you're going to proceed, rather than perceiving yourself, and this is just my take on it, as a victim of mandates. Sure enough, I am, as a practitioner, victimized, and I'm victimized by loss of revenue, and perhaps even some liability issues that I may or may not be aware of. I'm just saying that to keep an open mind. But that goes back to my original statement that we took a Hippocratic oath and we have a personal responsibility to do what's right for the patient in spite of what air traffic control may be telling us.
Yeah, well said. Unless you guys have anything else, I have some just concluding remarks. If I could try to recap this day, I thought all of the speakers were excellent. There were some common themes I think I heard. 1, physicians need to speak up. 2, physicians need to be bold. 3, physicians need to talk to our patients and the public, our hospital administrators, and our politicians to voice our concerns. Because again, it is only us and all of society who know what we do as physicians. And so there were some common themes I heard there. And I just want to kind of read this out, and then I'll close with some final comments. But this is something I wrote down a few months ago, and I'll just read it to everyone here. As our healthcare system continues to evolve, we need to ensure that these healthcare changes do not erode and disrupt the doctor-patient relationship. We should strive to maintain the art of how medicine is practiced between doctor and patient, and the sanctity of everything that occurs in the examination room. Furthermore, we absolutely need to tap into the collective wisdom of our doctors who are involved in the everyday care of our patients to bring insight and wisdom to the changes we are considering in healthcare policy. We can all agree that as a society, yes, we need to address both the cost and the quality of healthcare, but in the process, please, first do no harm.